The system of health care in the United States is going to change. Tonight, On Call looks at the future possibilities. The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Go hard! Whoa, whoa, whoa! Keep pushing.
Just your head.
Pull red handle to open bag.
How we pay for our health care should be a topic near and dear to every heart. But there are major issues about medical care financing that are overwhelming. First, the cost of it has gotten out of hand. We all need it, but if we were to paying for it out of our own pockets, many of us simply could not afford even routine care, let alone if a true emergency would occur or a severe and protracted illness. How can we fix this? Second, prior to the major health care bill that was passed, more and more people were not being covered, whether it was private insurance or government sponsored. Now that the health care bill is changing that, will it break the bank? What we have now is a mind-boggling, confusing mixture of payment for health care from private insurance to government payment through Medicare, Medicaid, the VA, Indian health care, and more. Is there any way to understand it all? How can we fix something we don't understand? Of course, this topic is political, and we cannot wade into it without sounding political, but I promise you all that I do not care where the solutions come from. What I care about is that solutions come. We simply cannot live and leave this issue unaddressed. To ignore would invite disaster. To help us understand this oh so very important topic, we have invited one of the nation's healthcare team leaders, Dr. Tom Dean. He's one of the 17 members of the Medicare Payment Advisory Commission, an independent congressional agency established by the Balanced Budget Act of 1997 to advise the U.S. Congress on issues affecting the Medicare program. This diverse national group of experts advising the financing and delivery of health care in the U.S. has only 2 physicians who are actually practicing medicine. And our Tom Dean of Wessington Springs, South Dakota, is one of them. This is a great honor to have you on our show, Tom. Welcome.
Thank you. I need to correct you. There are 3 now.
Oh, there are 3 who are practicing.
There's a new fellow just appointed.
Out of 17.
Yeah.
So how did you get on this commission? What's the story there?
The appointment to the commission is a little bit hard to explain. The appointments are, at least in theory, non-political. They're made by the Government Accounting Office and by the Comptroller General. But they don't tell you much about what their criteria are. There's no formal application process, although you have to express an interest. But they do try to put together a panel of folks representing a broad range of views and background to look at the Medicare program and to try to comment on it in a useful way.
And you represent, of course, a huge component. I would venture to bet you're underrepresented. I mean, the family physician or the primary care provider that's out there in rural America, how many of those are on that commission?
Yeah, well, I'm the only primary care physician and one of 2 or 3 people with some rural experience. And I think my appointment came because there was a concern that rural areas were not adequately represented.
Yeah.
But we are there, the commission, the leader, the chairman makes a very strong point that says when you come on the commission, you're there to help the Medicare program. You're not there to represent a constituency.
Right. You aren't representing.
No.
You're trying to do the right thing for the patients.
Exactly.
And what is this commission, this national commission, you know, this 17, this is like the most powerful board in healthcare out there. What does it really do?
Well, we meet regularly. We meet in Washington 8 times a year, so I've got a lot of frequent flyer miles.
Yeah.
But we spend 2 or 3 months looking at the various Medicare programs, and people don't realize that there are about 8 or 9 different Medicare programs. There's a program that pays hospitals, a program that pays physicians, a program that pays for dialysis, a program that pays for home health care, and a long list. So we evaluate each one of those as to how effective they are, how well the payments match the costs, and then try to give Congress advice about what the updates in the payments should be. That occupies about 2 or 3 months of our deliberations. And then the rest of the year is devoted to looking at the Medicare program from a whole variety of aspects, the quality of care that people are getting, the access they have to care, the other things that Medicare is involved in. For instance, Medicare is the biggest single funder of graduate medical education, which a lot of people don't realize, and various things like that to try to, and we continue to, and we produce 2 reports each year that go to Congress and certainly our public as well.
And you've been doing this for how many years?
I'm in my 5th year right now.
So really there's a growth phase that first year or 2, and now
it's overwhelming.
So you are a man who's had some knowledge. Before we get too buried in the numbers and budgets and national policy, we need to remember that healthcare has a human face, one area that is getting a lot of attention in the Medicare program, and it's rising costs and impact in the future of our older population. We visited with 2 people who have almost 50 years of combined experience using the Medicare program.
Well, I've been on Medicare since 65 years old, and I'm pushing 90, so I've had a longevity of activity under that particular system. It's been good to me. I've had the supplemental that goes along with it to pay the copay, and everything's worked out pretty well for me and for my past wife. As I reflect on Medicare and the problems of society growing older, it seems to me that part of the problem we're having with that program is that some of us are developing medical situations that require a large quantity of care involving thousands of dollars. And you wonder whether all of it is necessary.
Well, I've been on Medicare since since age 65, and of course, the last few years I have used it extensively, but I'm very satisfied with the care and the provisions that they offer. I do have a supplement, which is very expensive, but it covers everything, so that, like, if I have an operation that's quite costly, Medicare pays a certain percent of it, and then my supplement picks up everything else. The problem is, last spring I had a very serious eye problem, and I had to have some antibiotics compounded. Well, my drug plan didn't cover that. So that's something that people should probably check into and find out if you have extraordinary expenses in your drugs, so your plan would cover that.
I think it was around $270 a month for my Medicare supplement. And I've been in very good physical condition. Wellness programs and all that sort of thing, and walking kept me up until a couple of years ago. So I decided to take out a policy that had a large deductible. In fact, it's a $5,000 deductible. And I realized that I should cover myself with putting away the difference between the $58 a month that this $5,000 deductible costs and the $270, let's say, and put that away into an account that turns out to be a money account, so that it's available anytime. My situation was this. At 5 o'clock on Friday evening, the Friday of the Labor Day weekend, at 5 o'clock I was given a notice that my wife's time was up and she had to be removed from the nursing home. I was quite distressed, let's say, and I think it could have been handled a lot better. Anyway, I was able to appeal that, and she received another week, during which time we were able to get expert advice and change the house to accommodate her during her last 40 days of living. I wonder if the Medicare program needs to be changed in some way, that some portion of it might be, maybe 10% or something like that, could be accommodated by the family involved.
I think that's important, you know, if people could pay a little bit of their own money towards their care, they would be more cautious about going to the doctor for every little thing that they have wrong with them.
You know, we're talking about Medicare there, and some comments were made as she spoke about the need to pay a little something. It shouldn't be completely free, or we might abuse it. Is that something that we're moving toward?
Yeah, that's an issue that we've talked about quite a bit, and the data from Medicare utilization show that people with supplements do use substantially more care than people without supplements. And so I think there's a real consensus that what the lady said is right on target. We need to be careful that we adjust the co-payments so they're not prohibitive, but on the other hand make people at least stop and think a little bit, because the problem is when you put co-payments too high, people frequently put
don't
off
get the care
good
that
care
yeah.
and necessary care, and they don't do a good job at distinguishing between what's really necessary and what's not.
I remember 10 years ago thinking that appropriate copay would be the answer, and a study came out of the huge institute, I can't remember, that showed that indeed it prevented people who were poor from not getting the care that they needed. So you've got to have enough restriction, but not too much. What is that?
It's a tricky business. It's a real tricky business.
Well,
but I think we've got a lot of experience, and I think it can be done in a fair and reasonable way. And certainly we know that there's a lot of care that isn't absolutely essential that is being done. And we use something like, a lot of the estimates are that 20 to 30% of the care provided in this country, as measured by some very reputable researchers, really don't contribute all that much to the benefit of patients' health. So we have room to squeeze on that, but we have to be constantly careful that we don't limit people's access to the care that they really need.
Yeah. I'm on a carrier advisory committee, which means that this is, we get, Medicare teaches us what's coming down the pike. And they let us look at, okay, yes, we will pay for this surgery. Yes, we will pay for that procedure. We won't pay for this. We won't pay for that one, because this has not been proven to be helpful. This is very expensive and it has no value. But there are a number of these things that are kind of a little bit of value, but there's still, there's cheaper ways, and yet it has a rule that Medicare has to say all or none. It's a black or white deal. Couldn't we make a higher copay, like a 50% higher copay on something that has some value, but not a lot? And then, okay, if you want it, you can have it, and we'll pay 50%, but you got to pay the other half.
I think there's some value in that approach. The other approach that I think needs to be looked at, and in fact MedPAC has moved in this direction, is it's almost impossible to make those kind of rules from Baltimore or D.C. Those are decisions that need to be made on a local level, and so part of the Affordable Care Act is to encourage the development of a thing called the accountable care organizations, which would be, and the structure would be that a group of physicians, usually associated with a hospital, would be given a fixed budget to care for a certain number of people. And then we wouldn't be deciding what's necessary. They would decide what's really necessary. If they were able to control their costs and they were able to meet quality benchmarks, they would be rewarded.
In other words, let's say Sanford or Avera were accountable care organizations,
exactly,
and their cadre of physicians were all together, working together. They would be paid a certain amount for caring for this person. Now, this person got the cream of the crop therapy. They would only get this amount. If they got very little, the hospital accountable care organization would only get this much, same amount. And so it would constrain the accountable care organization to be careful with the money.
Exactly.
The problem is it may restrict. I mean, the less you do, the more they make. Right now...
Well, not necessarily. At least the way the accountable care organizations are structured right now, it's still basically on a fee-for-service structure. They don't... I probably misspoke a minute ago when I said they get a fixed amount. If they met certain cost benchmarks, they would get bonuses, is what it would amount to.
Well,
so, and you and I both know that good, efficient care is cheaper. And the thing that drives me crazy is, in fact, I get paid more if I do bad care than if I do good care. Because if I do a lot of extra tests and make mistakes and don't get the diagnosis right, I have more fees. That's backwards.
It is backwards.
It's absolutely backwards. We need to make sure that people get paid for doing the right things first and getting patients back on their feet and feeling good.
We have a system in this country that has emphasized subspecialty care and referral to the centers. And we haven't emphasized enough about a primary medical home. And some are saying this is important. How important do you think?
I think it's crucial. I think it's absolutely essential. And the systems around the country that are truly producing really good outcomes, and there are quite a number of them. I mean, some of us, get in the habit of being critical of this system, and there's a lot to criticize. But there are some very good systems around the country. And they, for the most part, are operating and producing care at significantly lower costs than the average. And they tend to use, they all are primary care based. They tend to use the medical home model in varying degrees and in varying ways. But one of our biggest problems in controlling costs is the lack of coordination of care. People sort of bounce from one segment or one part of the system to another, and oftentimes there's duplications, there's information that doesn't get passed on, there's conflicts between different treatments and a whole variety of things that end up adding to cost and diminish our outcomes.
Well, yeah, poorer quality.
Exactly.
But we think that the electronic medical record will help that.
It's a move in the right direction. We've got a ways to go, but it's a move in the right direction.
Good. And is Medicare getting broke quickly? I mean, is that concern?
Medicare is always stressed financially. We hear a lot of sort of inflammatory rhetoric about Medicare's going broke. In fact, the passage of the Affordable Care Act increased the projected life of the Part A trust fund by about 8 or 9 years. Right now, the Part A trust fund, which pays for hospital care, is projected to be solvent until 2024. That gets reevaluated every year. But it was down to, I think, 2017, a couple years ago. We've been there before. We've been down to as much as 2 or 3 years away from insolvency, and then things will be changed and we'll be adjusted. But I'm confident that there's a lot of things that can be done to make the system viable and sustainable, and it's just such a valuable program. We can't
Medicare.
Absolutely,
we can't let that die.
Can't let it die.
So whatever we do to pay for health care, we want to be sure to get the best value. We caught up with Dr. Stephen Berkowitz of a Texas health consultant at the South Dakota State Medical Association's annual conference to find out more about finding value in health care.
Dr. Berkowitz, quality of care and cost and systems, these are some of the things that you have expertise in. Explain to me what they are.
Well, we're faced with enormous challenges in healthcare today. We have a system that's very, very costly. We have a system that doesn't deliver really the quality results that we should get for those costs. And it's a non-sustainable situation. Now, having said that, I want to say right off the bat, I believe we can take measures that will make this much better. I am very positive about where I believe healthcare is going in this country, but I think there are some very definite things that we need to do.
Talk to me about the positives. What directions are we headed that you think are a good thing?
One thing I think that is really good is that we are starting to improve the quality and safety in our hospitals like we never have before. Now, we've got a long way to go, but when we look at issues such as bloodstream infections, blood clot prevention, and treatment of heart attacks, congestive heart failure, pulmonary disease, we're starting to see some of the outcomes really turn in our favor. We're seeing some very good moves in terms of increasing the safety in our hospitals, reducing falls, reducing pressure ulcers. Now again, we've got a ways to go, but we're seeing some results. Now I think one of the reasons that we're seeing these results is the data is increasingly public, meaning that the prospective patient has the opportunity to review data on the internet about hospitals that they may be going to and physicians that they may be seeing.
Now that's a new school of thought for patients like me who are used to just, you see your doctor and then you go through the system, you do what they tell you, and you're not really making your own healthcare decisions. How am I supposed to change my mind and see the new paradigm?
Well, the question is, do you really change your mind? Because we do that for everything else except healthcare when you think about it. If you want to buy a car, you shop around, you look at consumer reports, you ask your friends, you do various things, you test drive the car. I guess what we're seeing is as our industry matures, healthcare is really not a lot different. Now, having said that, people are very complicated, patients are very complicated, healthcare is very complicated. I don't want to say it's as simple as buying a camera or something like that, because healthcare is enormously complex. However, some of the fundamentals, we see differences in outcomes from one hospital to another. Some hospitals have more infection rates than other hospitals do. And there are differences amongst regions, procedures, physicians. Now, I'm not saying you should necessarily say good hospital, bad hospital, because that's simply not true. But what you can say is that we've got some data to show that some systems are outperforming other systems. And just like I want the best value for whatever I buy, I think healthcare consumers want the best value for their precious resources. You know, I think one of the most important things that the average American can do to improve his or her health care is to take personal responsibility for one's own health, which means understand the medical conditions that you have, know your risk factors, know your numbers, know your cholesterol, know your blood pressure, and take an active role. So your physician and all the other people in healthcare are going to be assisting you, and they're experts and they know what they're doing. But you have the responsibility for your own health.
Okay, thanks for some great information.
Thank you.
What do you think about that comment about personal responsibility? Will that save us money if we push personal responsibility? Where does that fit into the equation?
Oh, it's a central part of good health care, is trying to help people both understand their own situations, understand what contributes to their welfare, and to do the best we can. I mean, many of these habits, we know how hard it is to quit smoking. You know, it's terribly difficult, but we need to continue to try and help people to do that. The issue of obesity is frightening, And it's
gaining. We're losing ground on the problem.
And it's once it's established, it's really hard for folks to deal with that. But we've got to continue to work on it.
Well, and pushing people to exercise.
Absolutely.
Well, let's talk about the misinformation that's out there. I mean, people are panicking right now. I mean, what are they thinking, do you think?
Well, I think they fear that there's some big boogeyman in Washington that's going to take over and dictate who they can go and when they can go to the doctor and all of those things. That's really not part of reform. That's not part of good medicine. I don't see that happening at all. You know, we worry about socialized medicine. That's the big boogeyman that is constantly raised up. But even in those countries where they truly have fully socialized medicine, for instance in Britain, I lived in England for a year, many years ago, and they have their own choice of physicians. If they don't like their doctor, they move to a different doctor. So it really is, and actually to back up a minute, in many ways, Medicare is a socialized program. In fact, that was one of the big arguments against it when it was first proposed, was that it would lead to socialized medicine. It's one of the most popular programs this country has ever undertaken. So I think we need to look at the realities and not be frightened by some stereotypes.
Well, you know, your pledge to non-political, non-partisanship positioning, and now we have a partisan, polarized Washington, and many people on one side of the aisle are saying that the Obamacare, the Affordable Care Act, is a bad thing. We need to dump it. I mean, what's your position on that?
I've been a strong supporter of the Affordable Care Act, not because it's perfect. There are plenty of concerns about it, but it does. First of all, there are many aspects of it that the general public really isn't familiar with and doesn't understand. But it has a whole list of portions of it that help us to move to new models of care, more efficient delivery of care, and to help us to really deal with some of the underlying structural issues that are contributing to these outrageous costs. Plus, it clearly extends coverage so we can cover a large portion of the people that don't have care now, and that's important. The Institute of Medicine showed a year or so ago that there are 40,000 premature deaths in this country each year among those folks that don't have insurance. If they were covered by insurance, we'd
save 40,000 lives.
We'd save 40,000 lives. So it's not a trivial issue. It's a real issue. We're fundamentally not serving our public.
The way we were doing, we're right about 50 million people uninsured, and so the two issues that I think they approached was the issue of access to health care, coverage, insurance coverage, and the second is the cost. The cost one is so darn complicated. What they did with the ACA is they said, let's cover people and then we'll get at the cost. Would you say that's about right?
Well, yes, I think that is right, except that along the way it also saves cost, at least as best as anyone can project. And these are terribly difficult things to project. But the Congressional Budget Office, which is generally regarded as an independent, nonpartisan group, for instance, extended the life of the Medicare Part A Trust Fund once the Affordable Care Act was introduced, because it reduced Medicare costs even at a time when Medicare benefits actually increased. So there are things. One of the interesting things to me about the Affordable Care Act is the most unpopular part of it, by far, is the individual mandate, the requirement that people have to have insurance. One of the most popular parts of it is that insurance company have to take all comers and can't deny people because of pre-existing conditions. What most people don't understand is those two go together. If we lose the individual mandate, we probably will lose the other aspect, because if insurance companies are required to take people with pre-existing conditions, they say we have to have everybody in the pool.
Yeah.
Otherwise, people will game the system.
Yeah. What they'll do is they'll wait till they're sick.
Wait till they're sick, and then they'll get an insurance policy. And that won't work.
The insurance companies go right. It'll destroy the insurance industry, which which is, and paradoxically, we'd end up with a single-payer system.
Yeah, I think that's true.
I think that's true. So what gets me is, if you looked at the two parties, you would think that the Republican Party would be in favor of private industry, private insurance staying alive, and that you would have thought the Democrats would have said single-payer system, national health care system, and push it in that way. But what Obama did was went with trying to save insurance. And then he got the resistance of the Republicans. I don't get it.
Well, yeah, I mean, it's been talked about as a quote-unquote government takeover. It clearly is not. All care will be continued to deliver through the same facilities that we have now. Most of them are private. It'll be delivered by the same physicians we have now, which are mostly private. It'll be financed through private insurance companies, except for Medicare and Medicaid and those things. Yeah. So it's largely the same system that we would have now. But so actually PolitiFact, which is one of the nonpartisan fact-checking agencies in D.C., labeled the government takeover claim as the biggest lie of 2010. So
yeah, that is a lie. I truly think it is.
You know, and unfortunately, our system, our political system, has become so divided and so partisan. It really is frightening, because we have a series of serious problems that need serious discussion and serious compromise, and we don't seem to be capable of doing that.
Well, that leads me to think about that great important Supreme Court question that's coming up, you know. The question is, can we mandate people to have insurance? What do you think the Supreme Court's going to say?
Well, anything that I would say would be total speculation. The most recent appeals court, there was a very conservative justice who I understand is highly respected in legal circles, has said that it is constitutional. And so I think there's a fair chance that it will be judged constitutional. But obviously I don't understand the constitutional issues, and anything I would say would be totally speculative.
So explain again what you think would happen if they say it's unconstitutional, you cannot mandate insurance.
Well, it would really throw us into a tailspin, because as I said just a minute ago, we would also most likely lose the requirement that that insurance companies take all comers and don't judge people based on pre-existing conditions. We would probably lose that as well, which is one of the key problems that we have had. There's a lot of debate as to how a court would respond, whether they would throw out the whole law, whether they would throw out just that segment of it. So nobody really knows for sure, but it would create a tremendous uncertainty.
So, and then we have this uncertainty, and then, of course, they'd come up with a new law that would pass, right?
I'm afraid not. No, I think there's such division in Congress now that I think our chances of passing any kind of substantial reform legislation after this is at least a decade away.
So we're in big trouble if that happens.
I think if it gets struck down, we're in big trouble, yes.
That's scary words. Well, whether you believe it's perfect or it's flawed, the Affordable Care Act is causing us to make decisions and move forward on a health care reform way. Tonight, South Dakota Senator Tim Johnson is joining us from Washington to look at the Affordable Care Act and what it means for South Dakota. Senator Johnson, good evening and welcome to On Call.
Thank you for the opportunity to join you in this important discussion about the health reform law. Our nation has been trying to reform our health care law system for decades, and I am proud of the significant achievement we have made with the Affordable Care Act.
Tell us why you supported the Affordable Care Act, Senator Johnson.
I supported the health reform effort to give our nation the best chance of improving our health system and reining in costs. We will no longer remain the only industrialized nation in the world without some form of national health care. One of our biggest challenges has been that we spend more on health care than any other country and yet have poorer health outcomes than most. The Congressional Budget Office estimates that the reform law will reduce the deficit by $210 billion over the next decade. We cannot change the situation overnight, but the Affordable Care Act provides a path forward. and important tools to improve the way our system works for everyone.
Right now, how are South Dakotans benefiting from this bill?
The new health law has given people a fair shake when buying health coverage and increased protections from some of the worst abuses of the health insurance industry. Kids with pre-existing conditions can no longer be denied coverage. Young adults can stay on their parents' plan to age 25. Lifetime caps and benefits are prohibited, and coverage cannot be dropped when you need it most. Medicare beneficiaries can receive free preventive screenings and annual wellness exams. Those who reach the prescription drug donut hole are receiving an average of $600 annually on their prescriptions. Tax credits are also available to select small businesses to assist in the cost of offering health insurance. In addition, funding for community health centers has expanded access to care for people throughout the state.
Well, what do you see is going to happen with this act?
It is not likely a repeal would pass both chambers and be signed by the President. We cannot afford to turn back the clock on all the improvements the American people have seen in the last year. As with any sweeping reform, modifications will likely be made. I'm confident as American people become more familiar with the benefits, they will rely on it as they do important programs like Social Security and Medicare. The Supreme Court will take up for consideration next spring, and I'm optimistic that the law will prevail.
Well, what parts of that law yet to be implemented will affect South Dakotans?
In the coming years, seniors will continue to save on drugs as the donut hole is incrementally closed by 2020. Beginning in 2014, coverage must be extended to all Americans regardless of a pre-existing condition. State-based exchanges will be operational in 2014 to provide competitive private coverage options for uninsured, self-employed, and small businesses. Additional investments in our health care workforce will create jobs and ensure patient access to services in the future. As the Medicare payment system is realigned to promote quality over quantity of services, better patient care and system efficiencies will work to bend the cost curve down. Efforts to crack down on waste, fraud, and abuse are already underway and will continue to reap savings in the future.
Well, thank you so much for being on our show tonight, Senator Johnson.
Thank you, Rick. As implementation moves forward, I will continue working to ensure the health reform law is delivering for South Dakotans.
A lot of reassuring words there about the Affordable Care Act. Your response to Senator Johnson's comments?
Oh, I think he is right on. I think it's a huge change. Change frightens people, especially when they're dealing with a vital service. But it's a direction that we really need to move because we have our current system simply is not working for us.
They say that, okay, if the ACA, the Affordable Care Act, did two things, improve access and worked on costs, some would grade it a B+ on access and maybe a D+ on cost control. It seems to me cost control is such an important aspect, but it's so complex. Mm-hmm. Now, why do you think healthcare does cost so much? What's your take on why it's so darn expensive here in the U.S.?
Well, there's certainly no single answer. It's a number of factors. Our prices are much higher than they are in other countries. Coronary angiogram costs about twice as much in the United States as it does in most of the European countries where they do them just regularly and very effectively. We do more of them, and so that adds to the cost.
This is my grandma. She has Medicare. That's the government health insurance for zillions of older people and people with disabilities. If my grandma needs a doctor, or the hospital, or medicine, Medicare helps pay for it. But uh-oh, Medicare is broken. The government is gonna cut doctors' pay by a whole bunch. If that happens, half of the doctors say they might have to stop taking care of Medicare patients like my grandma.
Here's
the bad guy, the evil SDR. Boo! It's the SDR math. Bad math. Everybody knows it's bad, and it doesn't make any sense. But Congress won't get rid of it. But the SGR makes the government pay doctors less than it costs them to take care of Medicare patients, like Grandma. See, the black line is how much it costs doctors. The red line is how much the SGR pays doctors. It's way less. Boo! That's no fair. No, it's really not fair. The government pays lots of money to people like hospitals and nursing homes to take care of Medicare patients. That's this green line. They get paid more every year, but doctors get paid less. That's really no fair. Grandma's Medicare is kind of like her house. Doctors are the foundation, and stuff like hospitals and nursing homes are the walls. They all protect her. I like that. But look, the foundation of doctors is crumbling. If you don't have a strong foundation, the Medicare house will fall down on Grandma. You can't have a strong healthcare system without a strong doctor foundation. I like that the government pays hospitals and those other guys to take care of Medicare people. I just think Congress should pay doctors enough to take care of my grandma, too. I don't want to lose my grandma. I love her. It's time to get rid of that bad SGR guy.
Poof. That's... I mean, of course, that was the bias of a medical association in Texas. And, but there's a big problem about SGR. Could you put it in your words? What is the SGR and what does it mean?
SGR stands for Sustainable Growth Rate. It was put in place about 10 years ago, something like that. And the basis for it was that anytime Medicare expenditures exceeded a certain benchmark, that the next year fees would be cut to compensate for that overage. The first few years it worked. But what has happened over the last few years, there's been significant excesses above that benchmark. And instead of cutting fees, Congress has figured out ways around that. And so the deficits created by that have accumulated. And so right now, as of January 1st, according to current law, either the physician fees across the board would be cut about 28%, or there will be $300 billion added to the federal deficit. And so Congress has chosen not to deal with this, and each year that they don't deal with it, it gets worse.
And if you think about it, if a doctor's overhead, my overhead is 50%, well, it's more than that. But if it was just 50%, that 30% is from the top above overhead. So what it would do is it would be a 70% reduction in my income to care for Medicare patients. And you can imagine internists and family physicians caring for the elderly will just say, I'll take your cash. I'll be a concierge doctor, but I'm not going to take Medicare. Could be a big crisis if they let this happen and they don't solve the problem.
It needs to be fixed.
Let's address the issue of rationing of health care. A lot of people are afraid of rationing, and we're going to have to think about a way to control costs. How would you put it, what rationing is?
I've always said, flippantly at times, but also somewhat seriously, that rationing is a phony issue. It's a very emotional issue, but it's not a real issue because we have always rationed care. The only way that you don't ration care is you give everything to everybody. You have to have some kind of distribution system. The trouble with our current system is that we tend to ration care based on who has the resources to pay for it. And not totally, but to a large degree, that's what happens. I mentioned before that there's some serious consequences in that people without insurance,
That's rationing.
That's absolutely
Not
rationing.
letting them have insurance.
People without insurance tend to get care. They tend to get it later. They tend to have poorer outcomes. And as I mentioned, there's these studies that show that in the U.S. there's roughly 40,000 premature deaths each year because of that. That's rationing. So the question is not whether we will ration. The question is how we do it and what rules we use. And it seems to me rather than using, the rules should be transparent. We should understand how we're doing. It should be done based on what care we know is effective, that has a good scientific base. It's not easy, but we can be much more effective than we are now.
So my sense is that it's a false issue.
I believe it's a false issue.
Well put. Well, how did we get into the system for health care that we have here in the United States? It all started with competition among industries. For quite a few years, we, the people of the United States of America, have struggled with how to provide and pay for health care. There's an interesting history that got us here. In this country, during World War II, the federal government forced a wage control, thereby bringing companies to compete for the smaller workforce by giving employee health insurance benefits as an alternative to a higher salary. This health insurance trend was enhanced in 1954 by a tax break on businesses that gave employee health insurance. Thus, over the years after the war, we became a country where about 75% of health care was paid for by employer-based health insurance. But that left the elderly and unemployed without health insurance, and the nation started arguing about how to fill the gap for these people. In 1965, President Lyndon Johnson pushed through Congress 2 new programs to pay for health care called Medicare and Medicaid. Some thought then that our problems were solved, that everything was covered. However, this evolving system, which is unique to the U.S., different from all the countries of the world, has resulted in 2 huge problems. First, by 2008, more than 46 million people were not covered, since insurance companies had to compete by not insuring and avoiding high-risk and expensive patients. Second, because the more you do, the more you make, has driven our whole system of health care. Therefore, more services were provided, which drastically grew hospitals, subspecialist physicians, procedures, pharmaceuticals, and advancing technology. Some of this is very good, but it is very expensive. On top of this, our legal tort liability system has almost encouraged patients to threaten hospitals and physicians with lawsuit for any bad result, whether there was bad practice or not. The consequence has been a culture of health care which is driven to prescribe the highest level of technology available. And thus, we have the most expensive system in the world. In fact, we are twice as expensive as the world's top 15 most costly healthcare systems. President Obama's effort with the ACA, also lovingly called Obamacare, I think is a huge step toward providing insurance coverage for more people. But much more will need to be done for controlling costs. What should the politicians in Washington do next? So did we answer your questions tonight about healthcare reform, or did we cause you to have new questions? Either way, we will all be on this journey to affordable healthcare together for a long time. The best hope is that all the various stakeholders in the movement can get together and work out what should be the finest and fairest system we can build. Well, I'd like to thank everyone who helped make this show possible, including Senator Tim Johnson from Washington and, of course, our studio guest, Dr. Tom Dean. Thank you for watching. Until next time, stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.